I think another important area which still remains quite critical in making treatment decisions is the concomitant medication of our patients. And as usual, there's nobody better suited and experienced to summarize this than David Beck from Liverpool. He could always refer to his webpage, but we prefer to have him in person to give us an update on what is remaining to be important for us to know. David.
Thank you very much. So, where I come from, Liverpool is known for probably two things. One is the Beatles, still 50 years after they first came to the fore. And some people have heard of this guy, Ronald Ross, a Nobel Prize winner in 1902 for his work on demonstrating that mosquitoes transmit malaria. And from that, we built a school of tropical medicine, two in the UK, one in London and one in Liverpool. But I hope that Liverpool will also be known for not having people put their head in their hands when it comes to the issue of drug interactions. And we can cry help, like the Beatles cried in one of their songs, and help can be available in order to try to steer us through some of the morass of the drug-drug interactions. There are different reactions when you're faced with drug interactions. I'm not asking you to vote on this, but what is your attitude? That it's something straightforward to manage, something that you try not to think about, something to worry about, or something for someone else to worry about, such as if you have a pharmacist or you have a nurse practitioner, that's their problem, it's not your problem. So I think people have a different reaction to the way that they deal with drug interactions. When we're talking about drug interactions, we're talking about, from the simplest aspect, the HCV drug and a co-medication. And it's the potential for the HCV drug to cause a problem with the co-med, or is it the potential for the co-med to cause a problem with your HCV drug? And what we're always worried about are adverse events. Clearly, that is something that is always in the back of our minds, and potentially a loss of efficacy of one of your drugs. And so it's that balance between knowing what potentially could happen in terms of adverse events or loss of efficacy. And in order to really understand anything to do with drug interactions, we've got to understand what is happening in the body with our drugs. We need to understand whether you've got a wide therapeutic window or a narrow therapeutic window, and try to see if we have enough data to make a call about the potential for a drug-drug interaction. Now, I think the EASL guidelines and the ASLD, IDSA guidelines have recognized the issue of drug interactions by statements. EASL says numerous and complex drug-drug interactions are possible with DAAs. The ASLD says the introduction of DAAs has increased the risk of drug interactions with concomitant medications. So it's recognized in the guidelines that this is an issue. And both sets of guidelines point to some resources, including the Liverpool resources there, the hepdruginteractions.org resource. And this was used recently in data that was at the Berlin Viral Summit from colleagues in Hanover, who looked in an outpatient basis on the co-meds that were being taken, included over the counter, in 261 HCV mono-infected patients. And what they did then was to say, these are the drugs that the patients are taking. If we were to start them on a DAA regimen, what would it look like in terms of potential drug interactions? And they searched the database of the Liverpool website. Now you can see here, in terms of the number of co-medications, that 20% were not receiving any co-medications. But 80% of the patients were receiving between 1 and more than 10 co-medications. And so there's a whole range of different scenarios. Most patients being treated had taken one or more other drugs on a regular basis. And so the question is, what kind of drugs are people using? And in the cohort in Hanover, Proton pump inhibitors were high. Nearly a quarter of patients were on a proton pump inhibitor. Clearly a lot of cardiovascular drugs, beta blockers, angiotensin II antagonists, ACE inhibitors, and diuretics related to cardiovascular issues. And so you can see here the breakdown of the drugs that are being used in that cohort. And then the question was, if we were to put them on one of these DAA regimens, soft-ribo, soft-sim, soft-DAC, soft-lodiposphere, ABV3D, etc., what would it look like in terms of having to manage those drug interactions? And you can see there the percentage of patients with a potential amber DDI and the percentage of patients with a contraindicated, if they were to go down that road, the red, not recommended contraindicated drug-drug interaction. And apart from soft-ribo, clearly all the other regimens had a considerable number of the ambers, which are the ones you have to think about and say, do I need to monitor? What do I need to do? Is there something that I might have to dose adjust, etc.? So the regimens do have, as you can see here, in relation to real-life data, a DDI liability. And then in order to understand really how do we manage that, you go back to the pharmacologist, and I'm not going to go through this in detail, but the pharmacologists try to understand how these drugs are interacting as they're being absorbed through the GI tract and what happens in the liver, for example. And crucial to our understanding are the drug metabolizing enzymes, such as cytochrome P453A, and transporters becoming increasingly important. These shuttle pumps that shuttle things in and out of the GI tract into the bloodstream and in and out of the liver into the biliary canaliculi, etc. And they are the transporters PGP and BCRP, OATP, 1B1, etc. And you can see, and I'm not going to go into it in detail, that our DAAs interact in some way, either to be metabolized or transported by, or to inhibit these particular proteins. And then we have to consider renal mechanisms as well. Now, one area clearly of importance is in co-infection. And in co-infection, you have all your anti-HIV drugs, and then we have to think about our DAAs as well. And this is the table that appears in the EASL guidelines. You can see here across the top the DAAs, and you can see the HIV drugs as well. And just going through this is a static chart, and so sometimes there are slightly different nuances in the website as new data emerges. But you can see for SIM, for example, indications because of marked induction of SIM by the HIV drugs, efavirenz and etravirine and nevirapine, or marked inhibition, the other part of the coin, which you can see there for the boosted protease inhibitors. And so there are the reds for SIM. For DAC, there are the ambers, which you can highlight here. And again, you've got some degree of induction, which is known or anticipated, and that dose modification with DAC based on induction from the standard 60 up to 90, or a dose reduction, such as with atazanavir-ritonavir, or elvitegravir-cobicistat, where the dose reduction is down to 30 milligrams for DAC. It's not every boosted PI where that is necessary, as Ally2. I think the data we've got from PK and related to Ally2 potentially with darunavir, ritonavir. And then we look at lodiposphere, sofosbuvir, and again, this static chart possibly is a little bit confusing in terms of the ambers and the greens, because the issue with lead-soft and anti-HIV drugs is mostly around tenofovir, and the tenofovir changes that one sees on the backdrop of the regimen, the DAA regimen. And so all these asterisks down here, and one of the ambers links to that change in tenofovir exposure. Now, tenofovir is already higher in an HIV patient who's taking a boosted PI, and then you add in your DAA, and you can increase your tenofovir even more. So it's a tenofovir issue. And then we have the 3D regimen, again, where we've got some reds and some ambers because, again, of the induction effects that one can see with some of the enzyme inducers and the fact that you need to avoid ritonavir or avoid cobicistat in a regimen that has got ritonavir already in the regimen. Now, one of the things going forward with this tenofovir story is that tenofovir will be replaced by TAF, and because TAF is a prodrug which delivers well into the cell, into the lymphocytes, and circulating tenofovir is much lower, with ledipasvir sofosbuvir, for example, what you're seeing is no change in tenofovir, which is different from ledipasvir sofosbuvir with the fumarate, the TDF, which is the way that we deliver tenofovir at the present time. Now, there are some changes with this regimen. You can see that there are some PK changes, but it's not tenofovir that's being changed by ledipasvir sofosbuvir in this context. Going forward, if we go forward to what is down the line, then we have the Merck combination. And with the Merck combination, there will be definitely some contraindications not recommended because of the magnitude of the effect that one sees on grazoprevir and elbasvir with efavirenz, darunavir, ritonavir, atazanavir, ritonavir, lopinavir, ritonavir, massive increases and some decreases that you see with this regimen. And so again, what you're going to have is a number of drug interactions, and we're going to be looking at a restricted number of HIV regimens. So the challenge of drug interactions, what are the challenges that we really do face? In a sense, what I've outlined and what we really struggle with is when there are multiple drugs in the regimen. For example, a co-infected patient who's got other comorbidities, and working out all the potential ways that drugs could interact. Three-way interactions, for example. It's relatively straightforward to try and predict or talk about a two-way, but a three-way. Then the unanticipated interactions, which confound prediction. Or thirdly, predicting the interaction in a patient with hepatic impairment or an older patient based on data which has been produced in younger, healthy basically subjects for DDI studies. So this is really, I think, a challenge for us. And maybe that's been exemplified, one of those points, the unanticipated, just to highlight the amiodarone story just again, because I think it keeps reappearing as what is happening with amiodarone and DAAs. So let's just look at that. Remember what the communication was from the FDA. There were 9 cases of heart rate problems, bradycardia, 9 cases, 3 with ledipasvir sofosbuvir, 5 soft DAC, 1 soft SIM, 6 cases within 24 hours, 3 cases within 2 to 12 days of the DAA combination. Amiodarone's a funny drug. It's got a really long half-life of 50 days. It does interact with one of those transport proteins, P-glycoprotein. It's transported by and inhibits. And a number of mechanisms have been put forward as to what is happening with this particular drug interaction. What we've done recently is to use a scoring system to try to say, is there really a causal relationship between HCV therapy and amiodarone and bradycardia in these patients? And this was a scheme that was first put forward some 20 years ago. And you have to answer this series of questions, and we haven't really got time to go through them all, but number 1, for example, are there previous conclusive reports on the interaction? And you then score between -1 and +2. And you come out, when you go through all that scoring system, and we've done this, and we come out with a score of 7 answering all those questions. And if you look at the total score, 1 to 4 is a possible causal relationship, 5 to 8 is probable, 9 or higher is definite. And on our scoring system, we come out with a 7 of a probable causal relationship of this particular interaction. What is the mechanism? Well, this was put forward a few weeks ago in a paper by Vincent Soriano and colleagues that there may be a genetic basis to the interaction. The genetic basis being around this enzyme CES1, which is responsible for the metabolism of sofosbuvir to the 331007 metabolite. So if there was a metabolic defect, you would have higher concentrations of sofosbuvir. That increase in sofosbuvir could also be compounded by amiodarone inhibiting P-glycoprotein, therefore pushing sofosbuvir up. So that is what has been put forward. Now, the incidence or the rate of this homozygous mutation is around 3%, but amiodarone is really a very weak inhibitor of P-glycoprotein. So that would implicate sofosbuvir. Also, could it be that sofosbuvir plus the DAC or the liposphere is affecting GI transport, increasing amiodarone exposure? Amiodarone is transported by P-glycoprotein. Or could it be a local effect of the soft DAA on transporters in the cardiomyocyte? Because there's lots of different things fluxing in the cardiomyocyte, and maybe amiodarone's accumulating. Or could it be protein binding displacement? And this is the one, strangely, that myself and colleagues have gone for more recently, that it's an increase in unbound amiodarone that's causing the issue. Interestingly, if you go to the SMPC of amiodarone, it says too high a dosage may lead to severe bradycardia and to conduction disturbances. Okay, so a higher dosage, but if you have a higher unbound amiodarone, that's what's doing the work. So if you get some displacement and you get higher amiodarone unbound, maybe that is what is causing the problem. We don't have definitive proof, and it could be one or a combination of those ways forward. So let's just look at a case. This is a real-life case from one of my colleagues, 65-year-old male, currently prescribed all these medications. So here you are faced with this bunch of 16 different medications. So what are you going to do? You're going to put your hands up and say, help, horror show. Just look at all those different drugs that this patient is on. Are you going to feel comfortable at the interactions? Prescribe, ask your pharmacist, use the Liverpool website, focus on comorbidities to simplify treatment before considering HCV treatment. Well, that's always a good thing to look at all the drugs that the patient's on and say, can you stop any for the 8 or 12 weeks? So what are you going to do? Well, if you actually go to the website, interestingly, you've got 16 co-medications there. And if you look through all those different regimens, the number of ambers come out as being 4, 4, 7, or 4. There are no reds. There are no contraindications not recommended. There are just some ambers to think about. With that complex patient, there are some ambers to think about with the different regimens. And so here with DAC-SOF, there's just something to think about with amlodipine, digoxin, levothyroxine, and pravastatin. And in a sense, they're not massive deals there when you look through those particular drugs. The same with liposphere sofosbuvir. Monitoring heart rate, we do that. You've got, with digoxin, consider levels. We'll do dig levels anyway. Omeprazole, we know that we have to think about omeprazole dosing with liposphere sofosbuvir. And the statin, well, you're going to monitor, consider dose reduction. So in a sense, and even when you come with the 3D and people say, oh, complicated, it's manageable. Again, you've got 7 ambers. Some of them are pretty straightforward as far as just going through stage by stage and thinking about what you're going to do with each of these interactions. So it's not a matter because someone's got a lot of co-meds that you can't go down that road. But then we have to think about, beyond that, what if a patient's also on a recreational or party drug, such as GHB, MDMA, methamphetamine, cocaine, those kind of issues that certainly are prevalent in London and some other cities in Europe and Berlin, and I have no idea what the situation in Frankfurt is, but I'm sure that's true. And again, interestingly, all of those drugs there that are listed, I don't think there's any interactions with DAC or SOF or lead-SOF. Some ambers we'd have to think about with SIM and 3D. It doesn't mean that there's going to be necessarily an interaction of clinical importance, but it's at least something to remind the patients about and think about. So the question was, what remains relevant with HCV therapy? What are the issues that remain relevant? Number one, I think what we have to do is always consider the possible of DDIs with co-medications. And there are the co-medications and real robust data. Actually getting PK data in real-world studies is going to help us understand and see the importance of drug-drug interactions. Again, remember, most DDI studies have been performed in healthy volunteers. The way that drug interaction studies are done, we get some data preclinically, we go to healthy volunteers, and then in the patient population, can you always assume that your DDI will be the same, your drug interaction, in a patient with differential fibrosis and altered expression, potentially, of those transport proteins? Now, I can't speak to this, but I'm sure Graham can. But this is a paper that's ahead of print at the moment, which is liver toxicity associated with sofosbuvir, an NS5A inhibitor. So it's 2 cases. If you read that, this report describes 2 cases of serious drug-induced hepatotoxicity. Mechanism currently unknown. 1 patient was 74, co-infected with HIV. 1 patient was 37, a lady who'd got polycystic ovarian syndrome, had been on steroids. But few patients with decompensated cirrhosis being treated with DAA, so the exact PK in this population has not been characterized. It is possible that an unknown interaction or reaction to the drug combination caused the hepatotoxicity. Haven't got time to go into the details. I'm sure Graham could expand on that. But it's interesting, again, an unknown interaction. So thirdly, finally, we have to go through a stepwise approach to drug interaction management, asking the questions about, is the co-medication necessary? Can that be a discussion point? Is it possible to stop? If it is necessary, how do you manage it? Are there alternatives to the drug in question that's got an interaction within the same therapeutic class that you can change to? And you go through stage by stage and actually think through at each stage. And I would suggest that these drug interactions are manageable if we go through this sort of process. Thank you.